Hello everyone, this is Chadi Alraies from NCVH 2023 in New Orleans. I'm really privileged to be with Dr. Venkatesh Ramaiah. He is a vascular surgeon by training, but he has been doing phenomenal work endovascular as well. Dr. Ramaiah, thanks for being with us.
Thank you. Yeah. It's a pleasure being here at NCVH 2023.
Yeah. So we're going to talk about AAA and endovascular therapies from a vascular perspective. Tell us a little bit what's new and the approach to it.
See, abdominal aortic aneurysms were the 13th leading cause of death in the United States. And traditionally, when you had an abdominal aortic aneurysm and you had an operation, it meant that they split your belly, they treated the aneurysm, you stayed in the hospital for a week or so with tubes in the intensive care unit. Since 1999 September, endografts became approved in the United States. And now we do endografting, and most of these patients go home the next morning, and some of them even go home the same day. So the technology has morphed from open big surgery to the endovascular field. And the way we do it now is we don't even cut down on the groins. We do it percutaneous through the groins. The stent grafts have become smaller and lower profile. The technology has markedly improved, and patients are now benefiting from this less invasive field of medicine.
So tell us about your practice in terms of who go home same day, who go home next day, and what are the predictors?
So I'm the Chief of Vascular Surgery at the Honor Health Network in Scottsdale, and I'm also the co-founder of a Pulse Cardiovascular Institute, which is an outpatient, which is something, again, you need to address with your other colleagues. A lot of the cardiovascular procedures are going to the outpatient. It could be legs, it could be veins, and eventually even endografts, pacemakers, AICDs, coronary angiography, coronary interventions are all going to go to the outpatient. So the hospitals will be left with most of the sickest patients, which they should take care of.
Yeah.
So obviously not all aneurysms are the same. So if you have a very nice infrarenal aneurysm with good access vessels, those patients do really well. Your technique of fixing these patients depends on the indications and the criteria or the instructions for use of the device. Do not do something where the device is not really indicated. Like, for example, you have a short 8mm neck. You don't want to put a device that is indicated for a 1.5 centimeter neck. Obviously that graft's not going to hold, and the long-term outcomes are not going to be good. So stay within the indications, stay within the IFUs of the device. But then, like I said, all aneurysms are not the same. You'll have aneurysms that involve the renal arteries. You'll have aneurysms that involve the visceral branches like the SMA and the celiac. And so now, even for those, the technology has become so good that you can do fenestrated grafts, where the grafts are custom made to the patient's anatomy, where they have holes where you can get into the renal arteries or even into the SMA branches. So even these large thoracoabdominal aneurysms for which you make incisions from the belly to the chest can now be treated with punctures in the groin. Patients go home the next day. So the technology has markedly improved. Obviously, you have to follow these patients because the long-term data still shows that there may be changes that happen to the morphology of the aneurysm shrink, the grafts get dislodged. So the key, and which I'm very concerned about, is the compliance of follow-up of these patients.
Right. And after these interventions, patient goes home, is there any indication for antiplatelet therapy, or what's your protocol?
Not for large, because these are high-flow vessels in the aorta, but I think a dual antiplatelet therapy is a good option for some patients who may have stents in the renals or stents in the SMA and the celiac vessels. But a standard infrarenal abdominal aortic aneurysm, I don't think you need any anticoagulation, unless they are there for other reasons, for the coronaries and things like that.
Well, sounds like you make it so simple, Dr.
No, it's not. It's challenging.
It is challenging.
It's challenging, but at the same time, it's very exciting. And you know more. The same things are coming along in the coronary field.
Yes.
The same things are coming along in the peripheral field. You know, like in the legs and blockages, critical limb ischemia, saving limbs, saving lives.
Yeah.
So I think this conference, 2023 NCVH, is actually growing so quickly and tackling these issues of saving limbs, saving lives, preventing ruptures of abdominal aortic aneurysms, DVT treatments, carotid treatments, stroke prevention. It highlights all the technology, and I think it's a great meeting that Dr. Craig Walker has put together for the last 24 years. I think next year is 25. And I think we owe him a debt of gratitude for bringing these disease processes to the forefront and also developing technology to treat them.
Absolutely. Dr. Ramaiah, thank you so much for
Perfect.
introducing
It was a
us
pleasure
today.
talking to you.
Thank you so
Take
much.
care.
Please watch these videos and others on NCVH YouTube channel. This is Chadi Alraies from New Orleans. Thank you so much.
Thank you so much.
Thank you.
Take care.